Hello, hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network, and it is Sunday, February 15th of 2026, and it is time for another live IC support group meeting. Boy, do I have something I think that's really quite mind-blowing to share with you today. But let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I've been an IC support group leader for 33 years. I'm also a chemist. I have a degree in drug development, pharmacology. I have a master's degree in psychology. And I'm also a pelvic pain patient, just like you are. My pelvic pain began after I broke my tailbone when I was a kid. Of course, back then we didn't know about muscles and nerves. We all believed it was bladder stuff, but bladder therapies didn't work. Pelvic floor physical therapy did. IC patients essentially, or interstitial cystitis is essentially a grab bag diagnosis. What that means is that you get frequency, urgency, pressure pain, and they don't necessarily know what's causing it. And so what they do instead is say, hey, we think you've got this incurable bladder disease. Here's a diet, here's some medication, we'll see you in a bit. And of course, now we know that the IC patient population is very diverse, that there are a lot of different things that are very treatable that can cause these symptoms. Anyway, that's another meeting. Today, I've got two important things that I want to talk to you about. Recurring UTI. Now, if you have been online for an extended period of time, like I have, hello, I built the first website on IC 30 years ago. So if you have been online for the last 20 or so years, you're always going to find people who say, IC is embedded infection. They're very vocal people who say you all should be on antibiotics, that this is kind of a scam, for lack of a better term. And they suggest instead that every IC researcher is wrong and that every IC patient actually has what we would call an embedded infection. And of course, we know that that's simply not true. We know that the great majority of patients actually have muscle issues. 87% of patients have tight pelvic floor muscles. We also know that some patients have estrogen atrophy. Hello, Kayleen. Some patients have pudendal neuralgia. They have pain when they sit down that gets better when they stand up, a history of sciatica. But there is a group of patients who do struggle with actual recurring infections. And the thing is that generally these are older women who perhaps are not intimate. There are no structural abnormalities or prolapses or anything that they can find in these patients. And it becomes a bit of a medical mystery. And the bane of many urologists who get very, very frustrated because they give you antibiotics over and over and over, and inevitably the antibiotics don't work. There are three different types of patients who struggle with recurring UTI. There's a patient who you can give an antibiotic, and yeah, it does work. But there's a lot of patients out there, you give an antibiotic to them as soon, and it appears to help, and then as soon as you stop the antibiotic, the symptoms come right back. I've worked with many of those patients. And then there are some patients who have what we call pancystitis, where they've got just a very, very aggressive bladder-wide infection that's very, very difficult to treat. So guys, we are live streaming right now. When I'm looking down here, I'm looking at Facebook. When I'm looking over there, I am looking at YouTube. And so normally when I do these meetings, they can be anywhere from 90 minutes to 5 hours. It just depends upon your interests and your questions that they might have. Okay. Anne, hold that thought. Kayleen, hold that thought. Okay. So, recurring infection. If you're one of those patients, you've got 2 infections in 6 months, 3 infections in a year, you are officially a recurring UTI patient. And the mystery now is, where is it living? Where is the bacteria living that is infecting you persistently? There was an amazing interview online with Dr. Alan Wine and a doctor named Philippe Zimmern, who's at the University of Texas Southwestern, who for 25 years has been studying recurring infections. And he started following one of my favorite bacteria researchers, Scott Holtgren. I have shared a lot of Dr. Holtgren's information in our meetings before. He's got fabulous pictures of bacteria attaching to the bladder wall, bacteria burrowing into the bladder wall, white cells attacking bacteria. I mean, Scott Holtgren's research, I've heard him twice now speak. And if there's anybody that I would fly across the country to hear, it is him. And I've always said if I could go back to grad school, I would be studying drug-resistant infections like what he's doing. So anyway, here Scott Holtgren is studying recurring infection in mice. But we've got Dr. Zimmern, who's dealing with real patients who have recurring infections. And what Scott Holtgren finds is a population of bacteria basically living on the bladder wall. Like on top of the bladder wall. And a lot of people online say an embedded infection is a deep infection. No. These are very, very shallow infections. Think pimple. So Dr. Zimmern took a look at Dr. Holtgren's research and tried to apply that to his human patients. So the bladder is not all the same. We have got the trigone, which is a kind of a triangular piece of tissue that goes from the urethra up to the ureters. And then we've got the rest of the bladder wall. And the trigone is very different tissue. It's incredibly hormone responsive. Some of you have been diagnosed with trigonitis. So you have a cystoscopy and they look at your tissue and your trigone is bumpy. They call it a cobblestone-like appearance. It's just bumpy. And I can remember one of the very first things that I studied back 30 years ago when I was building the IC network was trigonitis. And a lot of doctors back then were saying, well, trigonitis is normal. We're not really going to worry about it. It's okay if there's bumps on the trigone. Well, and so I'm going to show you some pictures. So here is a picture of trigone tissue. And I want you to look at this. Do you see these bumps right here? Let me move it in. I mean, those are really clear, identifiable bumps, right? You can see them over here. And this one, you can't really see it as well in this picture, but if I move this in, you can see a lot of bumps over here. Okay. So what are these bumps? Dr. Zimmern says they're pus pockets. That these are actually kind of the equivalent of a superficial pimple on the bladder wall. And of course, one of the challenges that we have with IC research and bladder research is visualizing stuff. I mean, we know that, how do we see the infection? How can we say for sure that there's infection there? Well, one of his colleagues at the University of Texas created a new technology a couple years ago that fluoresced the bladder wall. And what I mean then is by doing this specific preparation, it made the bacteria fluorescent and easy to see. So he started using that technology to study the bladder wall in humans. And look at what they found. You see these little green things right here? That, my friend, is bacteria living on the surface of the trigone. And in some cases, the bacteria might actually be within the pus pocket. Okay, but anyway, so that's a very clear. They got really, really excited when they saw this for the first time because they could prove then that we have bacteria living on the surface of the bladder wall. Okay. So then, and let's see, here's a close-up picture of it. That's a much closer picture. Okay. Now, of course, the challenge with colonies like this is that they are in what we call a biofilm. A biofilm makes it very, very difficult to kill. So a biofilm, basically a group of bacteria come together, they create a little colony, and then that colony excretes this waxy coating called a biofilm over the colony. And it protects it, and it makes it very, very, very resistant to to antibiotics. You know, a lot of people are scared. Don't be afraid of biofilms because there's biofilms everywhere. This is how bacteria live, including good bacteria. But it is important to understand that if you've got a pathogenic infection living in a biofilm, antibiotics, odds are, probably aren't going to kill it. So how do we kill it? Well, he found a way. Now, for those of you who have Hunner's lesions, you may be familiar with something called a fulguration. It's where they use some heat. They use heat to seal the lesion and treat the bladder wall. This doctor, Zimmern, began using a very, 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 very light fulguration, like literally it doesn't go deep into the bladder at all. He doesn't want to do any damage to the bladder. We're talking, again, the equivalent of treating a pimple. We're only going to stay on the surface of the skin. We're not going to go deep into the bladder wall. And so in these pictures, let me see if I can show this. So here we go. If you can see this, you've got pus pockets right here on a human bladder. So what he did is he cauterized them. He fulgurated them. Very, very, very light. Only on the surface. And this is what it looks like afterwards. The pus pocket is gone. Okay, so again, pus pocket on the bladder wall, it is a continual source of infection. We're going to cauterize or fulgurate that spot, eliminating it. And when we get to the end, now we have healthy tissue. But when you cauterize it, you change the structure of the bladder wall. You eliminate something called a uroplakin. Uroplakins are what bacteria attach to. So when you cauterize this tissue, you get rid of the uroplakins, and guess what? It can't be infected again. It can't be infected again. So now the challenge here, and here, look, I've got the paper right here. Hold on, I need my reading glasses. Okay, so why do women keep getting recurring infections? Where are these infections coming from? Now, we think they're coming from pus pockets on the bladder wall. In his patients with recurring infections, he started looking at the trigone more closely, and he started noticing that these patients with recurring UTIs had trigonitis. They had inflammation on their trigone with a lot of bumps, a lot of little reservoirs of pus. And And what does he say here? And you typically see between each of these orifices in the bladder neck, here's some up. Let's see. Well, I showed you those pictures. Okay. Let's see here. Let's see. They had invaded the wall of my patient's bladder, and they were basically residing there, and that was likely causing the recurrence. This was our first major publication. And then their first big turning point was cauterizing or fulgurating that tissue. Now, here's something else I thought was so fascinating here. So there's no longer a uroplaque in here for the bacteria to attach to. So that's, it's important that once you cauterize the area, that you will not ever have infection in that part of the bladder again in that spot. This is done on an outpatient procedure under light anesthesia. It is a surface procedure. They do something with a bug bee electrode, so a very, very, very light electrode. So he says, very much, if you have pimples on the surface of your face, you don't want to damage anything below the surface. The procedure takes about 30 minutes or less. Recovery, though, takes time. And this is something else that I thought was fascinating. So, number one, patients, you're going to have urinary symptoms after they do this. Your bladder is going to react, so you're going to have more frequency, more urgency. You're going to feel like you have infection. You're going to go to the ER, and they're going to see white blood cells and red blood cells in your urine. And the ER docs are going to say, yeah, you probably have infection, put you on antibiotics again. And what he says here, no. That's what happens after you fulgurate, that it takes, are you sitting down, 6 months for the bladder to heal. And what if I always said in our meetings, the bladder is the slowest healing organ in the body? I thought that was fascinating. Okay, so after you've had it done, let's see. If it's intense, we recommend to limit fluid intake to rest the bladder. You don't go home and drink 5 gallons of water. That doesn't work well for you after these types of procedures. The usual thing we use, Azo, Cystex, and whatever else you want is to use is fine. Bleeding is rare. We do put these patients on a low daily antibiotics for the first 4 to 6 weeks because the symptoms are so similar to cystitis, but we will not continue if it's just the effect of the fulguration. So this is a simple prevention for a few weeks, after which we can discontinue if they're doing well. And the classic problem we run into is that they go to an ER for whatever reason during that time frame. They will get a urinalysis. The ER will find red blood cells, white blood cells. They will say you have an infection, but no, you don't have an infection. You just had a fulguration. That's why it's so full of red and white cells. And then how does it look 6 months later? It looks like a normal tissue. Now, what he says here is, for the doctor, it's very, very important that they follow up in six months. Don't do it earlier. It takes 6 months to actually heal. And the reason you look at 6 months is just to make sure that what you've cauterized has healed, and to make sure that there are no new lesions that have appeared, because bacteria can already be attached to the bladder wall. So before you declare the patient cured, go back endoscopically if you don't mind. Use your flexible scope. Look back from the top down, because the trigone is very easy to look at. Let's see. So the people who have the best outcomes from this are going to be the first 2 different types of patients. The patient who's got an infection, but they tend to be antibiotic responsive, but also the patient who, while they're on antibiotics, they feel better, but when they stop antibiotics, it comes back. Those 2 are the patients who are going to do the best. But he talks specifically about, how can I say this? Roots is not the right way. Understand that an infection is an infection that can grow. It can start in one spot, and if it's not treated well, it's going to grow. And so, so our goal here is to catch the infection when it's small. So if it's on the trigone, that's the best case scenario because they can just fulgurate that, and now we've eliminated that infection. If it's starting to go up the bladder walls, that too responds, but there are some patients where their entire bladder wall is affected, and those patients are the patients that they struggle with the most. But even, and so he just, he was kind of debating, how do we treat them? And in the end, if that patient doesn't respond to antibiotics at all, the next step is going to be to fulgurate. And if you got to fulgurate larger areas of the bladder, that's better than having to remove the bladder. So I am really excited about this because every now and then I do talk to patients who have been diagnosed with trichinitis, and we just really didn't know what those bumps were. And to think now that those bumps could actually be little pus pockets in the bladder wall, I mean, that's just kind of mind-blowing. All right, where'd my sweater go? Hold on a second. Ah, here it is. So I think, so they are starting another large clinical trial with this. This is Dr. Philippe Zimmern at the University of Texas at the Southwestern campus. I think it's absolutely fascinating. Well, how are you guys doing? Hey, happy Valentine's Day. Hope your Valentine's went well. I did nothing on Valentine's. I actually broke up with my fiance on Valentine's Day 25 years ago, and I just don't do Valentine's Day after that. It was very, very traumatic for me. All right, let's go through some of your comments here. Okay, so hold on one sec. All right, you guys. Hello, Mr. A on YouTube. Nice to see you again. Hope you're doing well. Let's go over here on Facebook. Anne says, can you find out if you have IC with a cystoscopy? Well, honey, IC doesn't mean anything. What does IC mean? So the point is, if they look in your bladder and see something, is that valid? Yes, but the question is, what are they seeing? If they're seeing Hunner's lesions, then yes, you've got Hunner's lesions. If they're seeing a bladder stone growing out of your bladder, then yes, you've got, a major issue with bladder stones. That often happens after really big trauma or if you've been very, very dehydrated. If you've got a tumor, God, we need to look and understand that. So a cystoscopy allows the doctor to visualize your bladder. That's always good. Listen, I don't like guessing. I like facts. If I'm in pain, I want to know why I'm in pain. And letting somebody look, especially if you've been in pain for 3 to 6 months, is not unreasonable. If you don't let them look in your bladder, you are forcing them to guess. And that is not okay. We need facts. So I've shared this story many times before. I was working with one of my clients who, for 10 years, she was afraid to let anybody look in her bladder. And there's a lot of you out there. And her symptoms were so persistent. And then finally, they just got so bad. She said, I don't care, just do it. And when they actually looked in her bladder, they found the underlying cause. She had a giant bladder stone. Bladder stones are like kidney stones, but they sometimes they can be kidney stones that don't pass through. But sometimes bladder stones occur when, I think it's calcium metabolism in the bladder wall is disrupted and calcium begins to emerge from the bladder itself in the form of stones. Okay, and I have a picture, so hold on a second. Okay, so if you want to see what a right here, you want to see what a bladder stone looks like? There you go. Look at that beast. that's growing right out of a friend of mine bladder wall. He had surgery on his bladder. It's a long story. This is not part of IC at all. This is more of a trauma response. Okay, so anyway, we've got a woman diagnosed with IC doing all sorts of bladder therapies, very expensive. Nothing is freaking working for her at all. She gets very, very severe. Finally, let somebody look in her bladder, and they found a giant stone. And if you look at this stone, it has rough edges. And not only do they have rough edges, but research has shown that they are freaking covered with bacteria. So she had a stone that was cutting her bladder or rubbing against her bladder all day, every day, as her bladder filled with urine and then drained. Once they got rid of the stone, she was cured. 10 years she suffered. 10 years she suffered because she let fear stop her from letting somebody look in her bladder. Don't do that. If your symptoms are not getting better, it's important to let somebody look to see if they can figure it out, because it could be something very simple, like an old stone. Okay. Kayleen said, I found some icy stuff out there, spread awareness like wildfire when it's in the hospital. Excellent. Every voice counts. Marcy says, I cured my IC by changing my diet, no citrus. I took 8 colostrum daily. It took me 3 years of agony being in a wheelchair. There you go. And with the colostrum, it's actually the lactoferrin in the colostrum. And so now we have research that shows that lactoferrin can make red inflamed bladders pink and healthy, and lactoferrin can help Hunner's lesions heal. So a lot of patients are now using not colostrum, but lactoferrin specifically. That research came out a year and a half ago. So I'm really, really glad you're better. That's awesome. Hello, Johanna. How am I? Girl, I lifted something heavy yesterday and I pulled all my incisions again. So I tried to walk yesterday, and it's like I have barbed wire wrapped around my chest. For those of you who don't know, I had a double mastectomy a year and a half ago, and the incisions are a bitch. They're so annoying. Katie said, I feel like when I lay on my right side, there is a spot on my bladder that is more sensitive. Sounds like that maybe that's the case. Katie, is absolutely possible. Listen, if you always have pain in a specific location, we have to understand what's at that location, because it might not, it could be a Hunner's lesion on your bladder wall in that spot, or it could be outside of your bladder. It could be a pelvic floor trigger point. It could be some scar tissue. That's really, really important that you've noticed that. Good. Now, next time you go to your doctor, we want to get more information about what is at that location. So for me, when I was younger, my hot spot was my perineum. I'm telling you, I felt like somebody had scrubbed my perineum raw with sandpaper. I had that for years in junior high, high school, and college. Like, what is wrong with Jill's perineum? And I took myself to many, many doctors. They all said, looks fine. We don't see anything wrong. And finally, my beloved Dr. John Renfrey, who has since passed away, said, Jill, you just have the most sensitive skin we have ever seen. Here's the thing. You want to know what's immediately underneath the skin of the perineum? Something called the perineal body. The perineal body is an attachment point for 4 muscles. When the perineum starts to burn, that's usually because you've got muscles pulling on the perineal body. And I haven't had that symptom since I have done pelvic floor physical therapy. Go figure. Marcy says, I drank marshmallow tea and took baths with comfy root to remove toxins. I've been in remission since 2005. That's fantastic, hon. So Marcy, here's the thing, back when you were doing that 20 years ago, we all believed that IC was an incurable bladder disease, but we don't think that anymore. Today we phenotype. Now we recognize that the IC patient population is very, very diverse, and we're not all the same. And you can see that just in a group, because for some people, IC begins in childhood, while for others, it begins after menopause. Same diagnosis, but are we really the same? And the answer, of course, is no. For some people, IC begins while they're going through chemotherapy because the chemicals of the chemo damage the bladder. Or if you're drinking a lot of diet soda, that's going to do the same thing. While for others, IC begins after they fall on their tailbone. Again, same diagnosis, interstitial cystitis, but are we really the same? And the answer, of course, is no, we're not. There are very distinct patient groups. And so for the last 10 years now, this is where all the researchers are chiming in, because now everybody's trying to define these groups. So Hunner's lesion, and each one of these patient groups has their own treatments. So we've got patients with Hunner's lesions. Hunner's lesions have now been connected to viral infection or a neuroinflammation specifically. Those are the two things we look for that causes lesion. Then we've got the estrogen atrophy group, patients whose symptoms begin after menopause, or if they're in perimenopause, or on Lupron, or if they've had a total hysterectomy. The bladder needs estrogen to make that nice thick mucus. If you don't have the estrogen, you don't have the mucus. That's not a disease process. That's the equivalent of estrogen atrophy or dryness. We've got the chemical injury patients. These are the patients whose bladders were injured in some way. Again, that's not a disease. That is a direct injury to the tissue. Our biggest group of patients are patients who are pelvic floor driven. Their symptoms often began after a trauma. They could have been an athlete. They could have fallen on their tailbone, fallen down the stairs, had a very difficult delivery. If they were having children, but this is very, very common in men. The great majority of men that we work with have a history of athletic. God forbid you be a bike rider, a horseback rider, anything that puts direct pressure on the pelvic floor. And of course, you have no idea that you have a muscle injury. You got all the symptoms of infections. You go to the doctor and you say, hey, I'm peeing all night long. It hurts. They go, okay, must be infection. They give you the antibiotics. The antibiotics don't work. You go back. The doc says, maybe you've got overactive bladder. They give you overactive bladder meds. They don't work. You go back. You eventually get the, God, I hate to break it to you, I think you've got interstitial cystitis. It's incurable bladder disease. And you are so relieved to have a diagnosis. You do everything they tell you to do. You modify your diet. You take the Elmeron. You take the antidepressants for 6 months, a year, 5 years, 10 years, 20 years. Now, here's the problem. You still freaking flare. Why? Why? Because bladder therapies will not fix tight pelvic floor muscles. The problem with tight pelvic floor muscles is something called ischemia or ischemia. The muscles are so tight, they're restricting blood supply to the bladder and to other structures in the pelvis. If your bladder is supposed to get 24 units of blood a day and it's only getting 10, you're going to have a healthy bladder wall? The answer, of course, is no, no way. And that's why patients who have pelvic floor driven symptoms are often diet sensitive, like I used to be. But if we restore blood supply with physical therapy to relax the muscles, the bladder generally heals. My bladder healed, finally. Okay, so 87% of IC patients have tight pelvic floor muscles. And it's kind of like the chicken versus the egg, right? Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. For a small percentage of patients, it begins with a bladder wall trauma like chemotherapy, the bladder or an infection, bladder screaming in pain. Of course, the muscles are going to get tight in that guarding reflex. So our therapeutic priority for that patient is treat the infection. When we treat the infection, we reduce the pain, the muscle should calm down. But that's the minority. The bigger majority are the patients whose symptoms began after a muscle trauma. Now we got muscles that are tight, and they're not just tight for a week, man, they're tight for years. Years. Some women out there have vaginismus. Their muscles are so tight you couldn't get a finger, much less have sex in their vagina, because their muscles are so hard and tight. That is injury/trauma. And that eventually is going to affect lots of tissues, including the bladder, including the vulva. You're going to have constipation, etc. So that's a big group. Our next group is going to be, it's a subset of pelvic floor, pudendal neuralgia. These patients have positional symptoms. They're fine when they stand, but when they sit down, it hurts. If you have sciatica, pain that shoots down a leg, you are the perfect example of somebody with a tight muscle squeezing a nerve. Therapeutically for these, we got to figure out the nerve that's compromised, where it's compromised, and try to treat that by calming the nerve down and releasing whatever's entrapping the nerve. And then our last big phenotype is going to be the widespread pain phenotype. These patients, and everybody in the world agrees, all the big researchers now. And the thing about the widespread pain group, so you've got IC, maybe IBS, maybe vulvodynia, maybe TMJ, maybe migraines, maybe fibromyalgia. Odds are you've got very sensitive skin, wicked sense of smell, anxiety disorder. Okay, what is that? That's actually an injury to the central nervous system. And therapeutically, what we've got to do is we got to calm the entire central nervous system down. And when we look at these patients more closely, as the Chronic Pain Research Alliance did, and as the big IC research team at the National Institutes of Health did, is when they studied the nervous system of patients who have widespread pain, here's what they found: a brain living in a constant state of fight or flight. 24 hours a day, 7 days a week, that brain is behaving as if your life is at stake. And the problem is it amplifies pain everywhere. Everything gets sensitive when you're living in a constant state of fight or flight. So therapeutically, we got to calm the entire central nervous system down. These are the patients who are going to do the best with kind of systemic therapies, might be a low dose antidepressant, but more importantly, therapies that will calm anxiety, doing some really good anxiety disorder coursework like I did 30 years ago, et cetera, cognitive behavioral therapy. And again, nobody is saying this is mental illness. Nobody is saying you are mentally ill if you have widespread pain. This is, in fact, the result of trauma. This is what a body does when it experiences trauma of some way. For 80% of the kids who go on to get widespread pain as an adult, there is a major physical injury, like being hit by a car, falling down the stairs, something big. And for the other 20% of us, it's a history of abuse or bullying, something that has interfered with your sense of safety. So growing up in the home of an alcoholic, especially a violent alcoholic, that's scary. That young child's brain is trying to save that child's life because they know that when mom or dad get home and start drinking, bad things happen. So that little child's brain goes into fight or flight to protect the life of that child. The problem is it's so long, it's years worth of this, that the brain just begins to live there. I grew up in a neighborhood with a kid who became a rapist and murderer. I was one of his first targets. I did not leave my home without fear for a decade. Okay, that is why I lived with anxiety for the first 35 years of my life. And I still have residual anxiety every now and then, because my brain went through big time trauma. But you don't have to live there anymore. Now we understand it. Not your fault, not my fault at all. All the trauma's gone. Today is a new day. But we really have to train our brain out of that trauma response. EMDR therapy, all that sort of works. It can certainly work and can certainly help. And there's a lot more discussion about other phenotypes. There's a mast cell driven phenotype, people with allergies. There is potentially, let's see, an autoimmune phenotype, but very small. And I know that, God, I was reading something yesterday. I got a message from one of the forums. And somebody was saying, well, we all think IC is autoimmune. It's not. Pelvic floor dysfunction is not an autoimmune disorder. Estrogen atrophy is not an autoimmune disorder. The only group that's going to have perhaps autoimmune dysfunction are going to be the Hunner's lesion patients, most likely, or if you happen to have another autoimmune disorder like Sjogren's or lupus. And that's, according to past studies, 3% of the IC patient population. So again, we're a really diverse group. So what's fascinating here is, and we're getting back to Marcy, who changed her diet, no citrus, took colostrum daily. That points directly to your bladder wall. So I would suspect that something was profoundly irritating your bladder wall to a great degree. Could have been pelvic floor. It's hard to say, but I'm just so glad that you're better. Good job. Johanna says, I'm having a flare right now. I didn't sleep last night. Going to the bathroom like 7 times. Honey, what do you think triggered your flare? Are you having a bladder wall flare or a pelvic floor flare or a stress flare or a menstrual flare? How do we figure out by your pain level? I mean, by where your pain is and when it occurs. So if you have pain as your bladder fills with urine, that it's relieved by urination, that points to a bladder wall flare. If you've got pain after you're done peeing, that points to a pelvic floor flare. So what do you think triggered your flare? Kayleen said she did a counter day and cuddled with your girls. They missed you so much while you were in the hospital. Yeah. Marcy said erosion of the lining of the bladder is what they found was wrong with you. Okay. So the blessing here is you protected your bladder wall while it was healing. And as we pointed out in this study that I was talking about earlier, takes about 6 months for the bladder to heal. So good job. Angie said, but the question is, why was it eroded? It would have been eroded potentially from estrogen atrophy. It could have been eroded from coffee, drinking a lot of coffee, drinking a lot of green tea, drinking a lot of matcha, taking a multivitamin that's high in vitamin C, ascorbic acid. You know, the bladder, like any other part of the body, can be injured. And generally, it's injured through chemical exposures. Mr. A says, I was diagnosed with trichonitis and you're a 27-year-old male. Pretty rare, I think. Thankfully, my symptoms are better now. But you had a tight pelvic floor too. And so you're doing good. Excellent. You know, we just have to follow the data. Sorry. My incisions are just talking to me today. Every time I move. It's like barbed wire across my chest. Okay, so I'm really glad that hopefully, are you treating your pelvic floor? All right. Angie said, hello, Angie. Nice to see you, my friend. Haven't tuned in for a while. Hope you're well. Flu is hitting my house. I turned 63 on Friday. Yay, happy Valentine's. Yeah, girl, listen, we're having our second go around of the flu now. So my sister's home has it again. Influenza A, this very severe flu. We all had it in early December after we all got exposed at Thanksgiving. And the second go around had my brother-in-law in the hospital. I mean, he's on oxygen now. This is a brutal flu. So, and very, very contagious. I kept saying, I want to come up and help. And she's like, no, do not come up, because if you get sick again, we won't be able to help you because we are all sick. And it's like, and they're who I rely on when I get really sick. So I have had to stay away, which just kills me because I want to help. Marcy said, exactly. They told me there was no cure. I did research, found natural cures. My whole bladder was affected. It was so severe, I felt like I was dying. Good for you. The only thing I would just say is that Cure implies you had a disease process. You healed. You heal an injury. You don't cure an injury. You heal an injury. And so if your bladder wall had been injured in some way by a chemical exposure, you did exactly the right thing. You obviously did the right thing for you. But it's very, very debatable as to whether it was actually a disease or not. I mean, we don't think of IC as an incurable bladder disease anymore. We think of IC as a pelvic pain syndrome for which there are many potential causes. Rosalie says, how much lactoferrin should you take every day? So the IC lactoferrin study did 1,000 milligrams a day for a week. Then they went down to 400 milligrams a day for 2 weeks afterwards. And then they did 200 milligrams a day for several months. And so if you're buying the lactoferrin in our shop, the pills are bigger. So what we're saying is you would do 3 a day for a week, 2 a day for 2 weeks, and 1 a day for several months, if you wanted to follow that protocol. Or you can just do 1 or 2 a day. Angie said, pelvic floor hair caused by scar tissue. Woo, I had a bad flare with my obturator internus. I had to either lay flat or stand up. That one was really hard to reach internally. Never saw my physical therapist in so many weird positions trying to reach it. Yeah, man, the pelvic floor these are muscles that are very, very hard to reach. Marcy said, now you have chronic tendinosis with no cure. What is that? I've never heard of tendinosis before. Hold on a sec. David bought the diet book. Excellent. I hope you like it. So what is tendinosis? Tendinosis, chronic non-inflammatory degeneration of the collagen fibers within a tendon, typically caused by long-term repetitive overuse rather than acute injury, results in a weakened, thickened tendon causing chronic pain, stiffness, and reduced range of motion, often requiring months of rehab to heal. Symptoms include localized pain that worsens with activity, stiffness, reduced strength in the affected area, sometimes a noticeable tender bump or knot. Number one cause is overuse, but it can also happen in aging. In some cases, untreated chronic tendinitis typically affects the elbow, the shoulder, the knee, and the Achilles heel. Because the underlying issue is degeneration rather than inflammation, recovery is slow, focusing on strengthening the tendon. Yikes. I'm telling you, this whole getting old thing, it's very, very frustrating. Man, I just like, what was it, like 2 nights ago, I just had random areas of my body just kind of throbbing in pain. My shoulder, my left shoulder, which is so weird because I was a tennis player, right? So this was when I was serving, this is how I was throwing the ball up. And man, the wear and tear injuries are real. Hello, Lisa White. How are stars valued? How many dollars for 1,000 stars? Maybe $1. The stars are not, if you donate stars, they're literally pennies on the dollar. I think the biggest payment I ever got in 1 month from stars was like $5. So stars, it's nice. Listen, every penny counts these days. I'm always happy to take stars, but if you want to support the IC network and support the work we're doing, it's better to come on over to the IC network and just make a donation. I would be happy with $10 or $5 or $50, whatever works for you. But the stars are, at this point in time, fairly pointless. Angie said, if I still had periods, I couldn't use a tampon. Right. Okay. Tight pelvic floor muscles. You hold all your anxiety in your pelvic floor. But it might not just be anxiety though, Angie. A lot of times it's a structural abnormality. There's something else going on that's just putting long-term pressure on those muscles. For me, it's my SI joint. It could be a bad hip. It could be a rotated hip. It could be a broken tailbone that's healed out of position. Could be a bad knee that has you limping, but most of the time it's how your foot hits the ground. If you're not walking normally, all that pressure and all those dysfunctional forces go right up your legs, right back into your pelvic floor. So that's why we always say, if you're working with a physical therapist, the most important question to ask that physical therapist is, are my muscles responding to therapy or are they always tight? If your muscles are always tight, we have to figure out why. And usually that's related to a bone. You know, we have what we call a bony structure abnormality. So for me, I have my SI joint is way too flexible. So my left piriformis muscle locks down very tight to stabilize the joint and hold the joint in place. Hello, Bonnie. The name Bonnie just implies happiness. So I hope you're a very happy woman. Joanna says, I get pain when you're trying to pee. Sometimes it's a lot of pee. It's a lot of pee, and sometimes it's just 2 drops. It hurts so bad, I have to kind of push the pee out. Girl, listen, if you have to push the pee out, your pelvic floor is involved. And never push. When you push, you're tightening your muscles and making them tighter. You never push and strain to get urine out. You were doing physical therapy, but the physical therapy woman told me it was nothing else for her to do because you're not able to give her an answer. Like, I feel 50% better. I can't say that. Some days are better and some days are worse. So, Johanna, what that tells me is that you weren't working with a well-trained physical therapist. You know, and that also tells me that you have muscles that are probably in a chronic state of chronic tension. And a good pelvic floor certified physical therapist should be able to figure out why that's happening. And again, and then the other thing I mean, girl, you've got to get this book. Where is it? Is it over here? Ah, here it is. If anybody should be reading this book right now, it is you, Johanna, because this is the Pelvic Floor Bible. This is the book that will teach you more about these muscles, where the muscles are located, and what happens when these muscles get messed up. And it will help you figure out why your muscles are chronically tight and chronically dysfunctional and why you're going up and down, up and down. So it's not just working with physical therapists to manipulate your muscles. This is about you diving in and taking charge of this too, because in the end, you can't be dependent on somebody when you have a flare. You got to learn how to treat it yourself. And this is a great way to get started with that. You can find it right in the IC Network website. I think we're down to our last 18 copies. Jerome Weiss, Breaking Through Chronic Pelvic Pain, best book ever, ever, ever written. It is, every time I read it, I learn more. I mean, I've already read the book twice, and every time I read it, I learn more. It's fantastic. And the images are really fantastic, like this for people who get symptoms because I was working with a patient just last week who was a longtime bike rider and now had pudendal neuralgia and sciatica and had a lot of symptoms. And it shows exactly what that bike seat pushes on that causes that. Oh, I just gave you the answer. Excellent. So you can find it in the IC Network. Just go to our store, go to books, you'll find it right there. Hello, Paula. All right, so guys. Okay, I have to admit, that I am getting older. I am not the young 30-year-old who started the IC network who could work on IC for 10 or 12 hours a day, which is what I used to do. I got a good 6 hours in me, and then I just have to stop. My brain says, you're done. And so my priorities have changed dramatically. I'm going to tell you right now, the IC Network Support Forum, which was the very first online support group, it still is the biggest support group ever. I mean, we've got, almost 1 million posts, 60 to 70,000 members, but it's not used that much anymore. Because people don't want to come and read stuff anymore. People want videos. It costs me $5,000 a year. I've spent probably $100,000 in the last 20 years keeping that forum alive. I can't compete with the free Reddits. I'm not going to put money into it anymore. I need that money for my retirement. And honestly, y'all just not using it. And so if you're not using it, I'm not going to pay for it. So, which is heartbreaking because it's such a giant archive of IC information. So things are changing. We have to respect the fact that times change. The forum will be gone very, very soon. I could write 50 books based on that forum. I'm going to try to harvest information to write more books, but fair warning. The other thing, since I don't really want to spend any time in the forum, I'm working one-on-one patients now. Today, I'm not worrying about the masses so much. My day, I just try to focus on one patient at a time and try to help as many people as I can that way, because I think that's more effective anyway. And some days I'm on the phone all day. Other days I'm writing. And we just finished our latest magazine, the IC Optimist. This is our Winter 26 IC Optimist. If you're a member, you can download this on your member page. I put them up yesterday. If you get it by mail, they're literally in my garage waiting for labels. We had to order more labels from Amazon and they're late. So we will be shipping out these as soon as the labels come in. So anyway, in this issue, my goal with this issue, let's see, how do I want to say this? I am freaking annoyed right now with, let's see, how do I want to say this? Researchers love science. I love science. I love science. I mean, I'm a nerd. Of course, I've got a bunch of science degrees. But in the end, we can't get lost in the idiosyncrasies of, does the bladder wall do this or that? We have a patient right now crying in front of us. What can we do for that patient? We have a patient right now who is not responding to any bladder therapies. Why? Because we're not going to send that patient home and say, you're going to have to live with this for the rest of your life. That's a crime. Today, we try to identify underlying causation so that you're not living with pain anymore. And so in this issue, I'm focusing on 4 conditions that are often missed by urologists. And the first one I talked about 2 weeks ago in our last meeting. So here, this is an amazing published case study of a woman who had severe pelvic pain. She had migraine, she had vulvodynia, she had anxiety, she had depression. She had to drop out of college. This was a very bright woman. She had to drop out of college because everything she just couldn't function. But what her doctors noticed was that her cognitive functions were decreasing. She started having problems with her short-term memory. She couldn't finish sentences. She saw 60 doctors and received all sorts of diagnoses, but nobody solved it until somebody found, I don't know who, probably a gynecologist, a varicose vein on her pelvis, on her vulva. She had a little swollen vein on her vulva. Now, that's very unusual and it's certainly not normal. That's a sign that we have a problem with blood flow. So the doctor who saw that then did more testing. And what they found was that her left iliac artery was more than 50% blocked. So why is that important? Well, that is a vein. Actually, it wasn't the artery, it was the vein. Yeah, it was the vein. That is the vein that returns a lot of blood supply back up to the heart. And if that blood supply is diminished or compromised, what that then means is that the heart cannot send good blood supply everywhere else, including to your brain. Hence her declining cognitive function. So when they did a stent and restored blood supply, within 30 days, her cognitive function had returned. And her daily agonizing migraines had reduced dramatically. And so anyway, pelvic congestion syndrome, the classic symptom of pelvic congestion syndrome is feeling a heaviness. You feel like there's a bowling ball in your pelvis. And the thing is when it builds throughout the day. And then when you lay down, it goes away. So you sleep fairly well. You wake up in the morning. As soon as you sit on the side of your bed, it begins. And as the day goes on, this heaviness gets worse and worse and worse and worse. And that's a sign of blood pooling in the pelvis. The cool thing here is it's completely treatable. So anyway, this is a published case study from about 6 weeks ago. We are also doing Lyme disease. Worked with a couple of Lyme disease patients in the last couple of months. Borrelia can actually infect the bladder wall. So it's quite common for patients with Lyme disease to have urinary symptoms. And we just had an alert literally in my local paper last week stating that they are now finding active Lyme in the ticks again, and urging everybody to be very careful and look for ticks. Listen, Lyme disease is essentially, I don't know if they would say it's neurotoxic. And if it doesn't get treated quickly, a patient can have effects for the rest of their life. It is a devastating infection and disease. I've got one friend of a friend whose daughter was bitten by a tick when she was a teenager, and her life has never been the same. Okay, then we're doing a new article on prolapse and the fact that if you have organs moving because of weak blood supply, that can cause all the symptoms that you would associate with IC, frequency, urgency, pressure, pain. Might be difficult to empty your bladder. Why? Because your bladder is now out of position, or sometimes your bladder is even folded over and urine literally is being blocked from emptying. Also an article on lichen sclerosis. Lichen sclerosis is an autoimmune condition that affects the skin of the vulva, and for men it can affect the scrotum. It can actually affect other parts of the body too. It is a wickedly painful skin condition that we often see in patients with IC. Let's see, what else do I have in here? I've got a big article on the global consensus meeting on new phenotypes proposed, the latest research. We have an article on building your flare kit. We have another article on starting a new year when you're already exhausted. I love this because I'm in this group. Like, I don't know about you, but life has been very stressful for the last year. And you know, part of it is just I'm a little bit older and I just don't have the energy that I used to have. But I think we all have to admit we're living in very, very difficult times right now. We have an article on recurring UTIs, an article on comfort food from the IC diet, and which is chicken casserole and chicken soup, and an article on overcoming fear. So this is where I think I do my best work, is in our magazine. It's what I enjoy doing the most. So you can get this for $25 a year as an book, as a PDF book. So if you want to sign up, come on over to the IC Network website. If you want it printed and sent to you, it's $50 a year. And that is because paper and printing is so expensive right now. Very, very expensive. And between that and postage, we can't do it for any less than that. So anyway, you can also buy individual copies. I think the individual copies are like $8. The PDF version is like $5.99, something like that. Super cheap, and it goes to support what we do. Okay. All righty. And then let's see, hold on. For those of you who haven't been here in a while, we of course have our brand new IC 101 Diet Guide. That is the latest big book that I finished. I wrote this one, although we have contributing articles from other authors in this too. And then, of course, we have the IC 101 Flare Guide. And you will soon see an IC 101 guide to the pain guide, and a couple more that I'm going to be doing, but I don't want to say what they are because I don't want anybody to steal my ideas. Because there are some people who watch my streams who then try to do their own things. So you're not going to get it all. My brain is alive and kicking, my friends. It is alive and kicking. All right, Angie says she has spinal stenosis, spondylosis, degenerative disc, bone spurs on L3, L4, L5, nerve damage in your right foot. I do see a back doctor in March. Chicken and the egg. Are my tight muscles pulling on my spine, or is my spine causing? That's a great question. I don't know. All right, you guys on YouTube, I'm sorry. Let me come back to you here. Mr. A was able to sleep through the night, but my symptoms were bad during the day. So although I had both tight pelvic floor muscles and trichonitis, I think pelvic floor was the primary problem, probably. G Jops says they thought I had lichen sclerosis, but when biopsied, I had lichen simplex cornices. I wonder what the correct spelling. Hi, Gwen. Hold on. Lichen. Let me see if I can figure out what that was supposed to be. Oh, lichen simplex chronicus. All right. Lichen simplex chronicus is a skin condition characterized by a chronic cycle of intense itching and scratching that leads to thick, leathery, and often darkened patches of skin. Common areas include the scalp, the neck, the ankles, and the genital region. Treatment focuses on breaking this itch-scratch cycle using topical steroids, antipyretics, and stress management. You know, Dr. Pimple Popper, who I love watching Dr. Pimple Popper, she introduced me to a tape that you can put on top of an area that's very itchy that releases medication into it. And I ended up getting that because I have, what do I have? It's not. Oh, it's right on the tip of my tongue. I get these little red spots that can really itch, sometimes on my shoulders. And is a specific name for it. It's going to happen if I take like long hot showers. And anyway, they gave me that. I actually have it in my bedroom. I should go get the name of it for you. Am I running a special for my new food book? No, it's already deeply discounted at $16.95. I'm telling you right now, $12 goes into printing for that. That is not making me a lot of money here at all. I'm going to have to raise the price up to 18 or 19. We are going to sell it on Amazon also. I just don't have the ISBN number. That's on my giant to-do list of things to do. You know, my brain just goes when I look at my to-do list and I just check out. It's like I have to walk away. That's being 65 years old, my friends. That's just what it does. All right, Tasha. Let's see what Tasha has to say here. Tasha has a long post. Girl, you don't need to beg. I'm here. Let me read it out loud for everybody. My first symptoms started after a very premature delivery of my daughter in 2013. You had to have an emergency hysterectomy due to hemorrhaging. Oh, honey, I'm so sorry. After we finished our 2-year breastfeeding journey in 2015. Since then, life has not been the same. Prior to this, let me ask you right off, was it a total hysterectomy? Did they take your ovaries too? So we'll come back to that. Since then, life has not been the same. Prior to this, I was a very active, healthy young lady. As the years went on, I had countless UTI infections every few weeks, plus lots and lots of blood, plus chronic kidney stones, recurring surgery, straining to pee with severe urgency. No results. It was at that time I was urged to have an indwelling urethral catheter. Was unable to tolerate due to pain and increased blood in my urine. This went on for 2 years. They gave you lots of medication, typical IC medications. When the meds failed, I was even given a suprapubic catheter in 2023. You did okay for a short time. That's when things spiraled to the worst. I was then advised there was nothing left to do for me, and I was diagnosed with a severe form Fowler syndrome and severe IC. I was referred to another urologist in another city. You're from Canada. The urologist recommended axonics in January. While it did help me pee on my own for the first time in years, it still required great effort and a lot of straining to the point of major urethral swelling and bleeding. 2 weeks later, I'm now fully dependent on your catheter again because of major spasms to the point you're straining so hard, you bleed a lot from your urethra. Oh, honey. Met with a urologist last week. You discussed bladder and urethra removal or bladder augmentation, but that would be of no help. Currently, you're in extreme pain. You can't leave the house. You're up all night crying. This is horrible. First of all, this is a hug. So I'm giving you a hug right now. I'm so sorry that you're going through this, hon. You're not alone. You're absolutely not alone. Okay, so if you don't mind, let me just I'm going to pepper you with some questions. So hopefully you can respond quickly to those questions. And Gwen says, hugs from Arizona. Okay. So not every IC patient is the same. Understand that. And there are triggers, very consistent triggers that we often see in patients. And there is a group of patients that I call surgical injury patients. So these are patients whose symptoms began after a medical procedure gone wrong. And so When you had your baby, we're dealing with the trauma of childbirth. You don't say if you had to have a C-section or not. Were there any injuries during childbirth? Did anything happen during childbirth that you can remember? Okay, that's question number one. Question number two is, you had to have an emergency hysterectomy due to hemorrhaging. What was bleeding? So what specifically was bleeding? Was there an old, were you, was there an old injury that was just bleeding all the time that they missed from the delivery? So Tasha, those are my first two questions for you. Is what happened during that delivery? And what did they tell you was bleeding? So you had a C-section and you had HELP syndrome? I think your spell corrector changed that. What syndrome did you have? Oh, you had placenta abruption. Okay. And high blood pressure leading to okay, girl. So you had just a horrific delivery. So you were bleeding through your vagina. But what was bleeding? I mean, we know where it was coming from, but I'm assuming that they looked to see where the blood vessel was that was bleeding, right? And you were 26 weeks pregnant. Were you having any bladder symptoms during the pregnancy? Prior to the pregnancy, you had no bladder symptoms. During the pregnancy, were there bladder symptoms, or did this all begin after the delivery? No answers other than a ruptured placenta. Yeah, but the placenta after the delivery should have been gone. So it's like, okay, so something didn't heal. That's a fair statement, right? That apparently something didn't heal after that. Did they look? Like, did they actually go in and look at your uterus to see if they could find what was bleeding? And you're in Canada, right? I mean, listen, healthcare sucks everywhere at this point in time. Okay, so again, Tasha, no bladder symptoms before you had the baby, right? No history of bladder symptoms, right? I'm just waiting for her to answer. No, they just did a radical hysterectomy. The doctor sucked, and so did the care. Okay. So, and it was a total hysterectomy. They took your ovaries too? Hold on. Okay. So this is what we know. You had serious pelvic trauma, and they put you into menopause. And they took your ovaries, they put you into menopause. So think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. So urine contains ammonia and urea. So how does the bladder defend itself? Well, it turns out your bladder is like your mouth. It's a hollow organ that's wet and slippery on the inside. There is a really thick coating of mucus in the bladder that acts as a barrier protecting all the skin. Okay. It pushes urine away from the more fragile cells of the bladder wall. It's basically hydrophobic. The problem is that mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you got a lot of mucus. Once they took your ovaries, they put you into menopause. So now we know that you also are now at this point in time probably a very severe estrogen atrophy patient. Your bladder wall is very dry. Your vagina is probably dry. Your vulva is probably dry. Which means then, again, okay, so hold that thought. So Tasha, we got to break this down into structures because it's not one giant thing. Okay, there are different things happening for you right now, and we've got to be a detective. You've got to be a detective. So we're going to focus on different things. You got to get answers to different things to help us try to understand what's happening. So they have told you that you have estrogen atrophy. Did they give you anything for it? Did they give you estrogen to use, an estrogen cream, especially at your urethra? If you give that skin estrogen, it plumps up and it starts to produce mucus. You probably should have been on estrogen for ever since surgery. So are you using any estrogen? Cream. Okay. How often are you using it? Like 2 or 3 times a week? You just started? Okay. Don't walk away from that. Listen, I've worked with some ladies who by the time they're, 30, 40 years after menopause, their little vulvas are like dry potato chips and they're in agony. The quality and health of your skin is really, really important. So you've got to be attentive to the quality and health of your skin. Okay. Because in the end, that's going to affect everything. Now, Tasha just said here, she's got bloody mucus pouring from your urethra. Okay. That's a huge problem. Because now, before your bleeding was coming from your vagina. Now something is bleeding in your urethra or your bladder. Do we know what's bleeding? Is it your urethra? Is it your bladder? Is it your kidney? Has anybody told you what's bleeding? Have you had a cystoscopy? Have they looked at the tissue to see what's bleeding? Okay, from the bladder. Is it coming from one spot on the bladder? Okay, you've had tons of cystoscopies. When we think of a bleeding bladder, the first thing we're going to think of is a Hunner's lesion. Does this patient have an open wound on their bladder that is bleeding profusely? Hunner's lesions can bleed profusely. Your entire bladder is raw and inflamed. Okay, were you ever diagnosed specific? Okay, no Hunner's. Okay, that's good. So that's really good. So how did your doctor explain the fact that your bladder is bleeding? Okay. Like she says her urine is red like cranberry. This is really bad. I mean, we have to understand what's bleeding. So maybe the blood's coming from somewhere. Where is it coming from? Okay, but again, it's not the whole bladder isn't oozing blood. A portion of the bladder is oozing blood. So normally when you have a bleeder, they cauterize it. So did they cauterize any bleeders? And you guys, I'm just waiting for her to answer here. I mean, because an axonics is not going to stop a wound from bleeding. You've got a wound, you've got something that's bleeding. We have to find that and treat that. So did the doctor ever cauterize or laser? Okay, so you're saying you've got frequent kidney stones and they cauterize your bladder every time they go in with a scope. Okay, so then the second thing that we have to think about is infection. Because if we have a very badly infected bladder wall, that's going to bleed. So hold tight here. Just follow we just got to go through the list here, Tasha. So have they eliminated infection as the source of your bloody urine? Have they done proper urine testing to make sure that there's not an active infection going on? Okay, who told you you have embedded infections? Who told you that? Did a doctor tell you that? Or did you get that from the internet? You have Pseudomonas and staph. Okay. Are they treating it? When did they find that infection and are you on antibiotics for that infection? So she's got Pseudomonas and Staphylococcus. So are you on antibiotics at the moment? Or when did you stop the antibiotics? You're on gentamicin installations and Cipro, and you're still on them. Has the blood gotten worse or better? You're on both of them right now. Is the bleeding getting worse or better or staying the same? How long have you been bleeding? How long has this been going on with the blood in your urine with this current infection? Has this been a week, 2 weeks, a month? Okay. You've been bleeding for 3 years? You must be anemic now. You must have anemia now. Well, this is awful. Okay, hold on. I got to go back up here and read what you wrote. Didn't you say that you got referred to? I mean, this is really unacceptable. And you're getting transfusions every month because you're bleeding. Oh my God. Girl, I just want to like give you the biggest hug in the world. This is brutal. Hold on, I'm just trying to go back to your original post. The third thing that concerns me is the fact that you're straining so hard to have to urinate. And I have to wonder what the health of your pelvic floor is, because girl, I mean, this started after that hysterectomy and after having that baby. Have you had listen, that's not why your bladder's bleeding. I mean, you could be in really severe ischemia, which is going to affect your bladder wall. But given the fact that a lot of this began after you had that hysterectomy and in all likelihood, some sort of surgical injury or trauma, what's the health of your muscles down there? Your Calgary urologist gave up on you and sent you to one in Edmonton every 15 minutes, not even to pee. The spasms are constant. Are they bladder wall spasms or are they pelvic floor spasms? Like, do the spasms begin while you're peeing? You have total atrophy. I'm not surprised. You should have been on estrogen, 10 years ago. So your skin, think about somebody who's very elderly. All you have to do is just touch their skin and it tears. So you could have very severely atrophied tissue that's just kind of torn. Your urethral sphincter. Okay, what about your muscles? How are your muscles? Your pelvic floor. Okay, I get that. Yeah, Angie, you're exactly. Tasha, at this point in time, your medical system has failed you. If you've been bleeding for 3 years, if you've had blood in your urine for 3 years, I'm so okay. Your muscles are totally tight. I think you need to come and see a pelvic pain specialist. And as Angie just said here, we have a fantastic diagnostician, probably the best in the world, right outside of Detroit. His name is Ken Peters. He's the chairman of the urology department at a place called Corewell Health. He's where we send a lot of our Canadian patients who are struggling. Yeah, honey. We should talk on the phone. We should really talk on the phone. My phone number is on our website. I talk to patients in Canada all the time. I mean, so you've got three possible things going on. Number one, for sure, your skin is toast. Your skin is toast. You are in severe atrophy. The blessing here is estrogen works. You're just going to have to just stick with it. Don't stop it. I mean, so you got to stick with it. We got to get that skin as healthy as we can. Estrogen does that. Does your urine ever feel hot, like it's burning you? Thank you, Angie. Does your urine ever feel hot as it's coming out of you, like it's burning you? I'm just waiting for her answer here. It's okay, Gwen. You're good. She says it feels like it. I know everything feels like acid in your bladder, though, honey. Even your muscles can cause that symptom. The second there's urine touching my bladder, it feels like acid. Okay, so these are the things that I think have to be explored. You're already doing the estrogen. Good. Number two, we've got the fact that you've got active infection is okay. So hot. Okay. That's a sign of atrophy, hun. If your urine feels like it's burning you as it's coming out of your body, that actually is atrophy. That is the symptom that estrogen atrophy causes. And it will feel like it's burning your vulva. It will feel hot in your urethra. The topical estrogen should fix that. Okay, that's going to help tremendously. So that hot burning sensation is, especially on the vulva, is atrophy. One of the things that you can use in addition to your estrogen is some coconut oil. Although coconut oil is a little messy, or you can get some vulva balm, which you can use every day on your vulva to protect the skin. This is just an organic oil complex. This is what it looks like. This is literally one of our best-selling products, and I use it myself. It's a very, very, very light oil that mimics your normal mucus. Okay, so we know you've got severe atrophy. We also know that you have very tight pelvic floor muscles, and that's probably from the hysterectomy, right? I went into involuntary muscle spasms after my hysterectomy. I had involuntary pelvic floor spasms for almost a year. And so you say you did physical therapy, it didn't help. The question that I'm going to ask you is, were they doing internal massage? You should be able to get it on Amazon, hun. You can get it from us. We send to Canada every day. So you can go over to the IC Network website and order it, and we can send it to you too. It's just the shipping's a little bit expensive, or a lot expensive, depending. Okay, so when you went to physical therapy, what did they find? Tight muscles. How did they treat it? How did they treat it? Was it a finger in your vagina massaging the muscles? Did they do that? Okay. So again, she says, I don't care. I'll do whatever it takes. Girl, I could totally understand. I get it totally. Okay, so now we're going back to your muscle health for a moment. You said physical therapy didn't help. Okay. A lot of people drop out of, okay, they did internal massage. Good. How many times did you go? And was your muscle tension on the left side or the right side or both sides? So what specifically did they find when you went to physical therapy? Left side, right side, or both sides? Okay. But what did they find? Both sides. Okay. Was it shallow or deep? Did they tell you the name of the muscles that they were working on? Were they working on the levators, the obturators, or the piriformis? Because you got 3 layers of muscle: shallow, medium, and deep. The shallow layer is levator, the mid-level muscles are obturator, the deep muscles are piriformis. Did they ever identify which muscle was the problem? Ooh, it's getting cold here. I feel it. My furnace is at 66. I might have to go turn it up. Honestly, you don't remember. She worked on all the muscles she could reach. Okay. How long ago did you do physical therapy, hon? How long ago was this? And while you're answering, I got to go turn my furnace up. I'll be right back. You'd have to pull your records. Okay. Okay. It's time for some polar fleece. Hold on. Okay. Johanna says, and I thought my pelvic issue was bad. Yeah. 2 years ago, just before the suprapubic catheter, and then she said she couldn't help me, that it was beyond what she could do. Okay, so your case exceeded her skill set. Did she refer you to somebody else? I mean, that's not your fault. That's not your fault at all. You have a complex case. You need to be with a fully certified pelvic floor physical therapist. Somebody with a tremendous depth of experience here. I would suspect, again, your symptoms started after a very, very difficult childbirth and surgery. So this is not a disease. This is injury/trauma. I mean, your infection is a disease, but the underlying cause still goes back to some sort of trauma. No, honey, there's no reason for you to assume that. You can treat the infection, we can treat the muscles, and we can get the skin health. Okay, I know, but you say you're at the top clinic. Girl, they missed the most obvious cause, which was estrogen atrophy. It's shocking to me that you were not given estrogen after you had your hysterectomy. So your atrophy, your tissues just got weaker and weaker and drier. So, not your fault. You haven't done anything wrong. Your medical system completely failed you. But here's the thing, the human body is always trying to heal itself. Healing is always happening. Healing never stops. The challenge here is identifying the actual underlying problem. You got a bunch of stuff going on. You are in severe atrophy, but they're addressing that. It's going to take a couple. I mean, you just keep on with the estrogen and use the coconut oil or use something like this, and that'll protect your skin. Okay, so that's solid. Number two, if your muscles continue to stay tight, and you have to strain to empty your bladder, man, that's bad. We have got to get that fixed. And so this is where you've got to be the very, very squeaky wheel. You can't just walk home and give up, man. It's like, wait a second. Clearly, my muscles are effed up. I had a physical therapist who did not have the skills to deal with this. I need a referral to somebody to do it. They want to remove your bladder and your urethra now. Well, that's an option that can be life-changing for the better. It's a big surgery. It is a big surgery. The people who generally have their bladders removed are patients whose bladders are profoundly diseased and not responding to therapy, and they've gotten very small. But removing your bladder is not going to fix tight muscles, right? So the people who do best with bladder, and I've worked with many patients who've had their bladders removed. Before you do that, you probably need to go see a true world leader like Ken Peters in Michigan. Even if you have to pay out of pocket, I mean, they work with patients from Canada all the time. You need a proper diagnostic workup here. You know what? What I want you to do is I want you to call me this week because he's a friend of mine. I can send him a letter and kind of summarize your case. And you can't, okay, wait a second. You cannot even hold 10 cc's of urine. You can't physically hold 10 cc's, or 10 cc's cause agonizing pain. Like, what if they said your actual bladder capacity is? What is your bladder capacity? When they've done your cystoscopies and your hydrodistension, have they measured your bladder capacity? And what is it? Is it 250, 200, 150? What's your bladder capacity? I mean, they have to measure it. So they should know what it is. So have they ever told you what your bladder capacity is? Okay, so it's not that your bladder is small, it's that urine kills you. That anything touching your bladder causes agonizing pain. Okay, your capacity is under 100. So under general anesthesia, her bladder capacity is under 100 cc. That's getting small. That's getting small. Yeah, Estelle, she's having horrific pain and blood in her urine. What was your official diagnosis? What did they diagnose you with, Tasha? You said interstitial cystitis, and what else did you say? Fowler syndrome? I see you guys over on YouTube. All right. So for those of you who don't know, Fowler syndrome, just to give you a thing, it's a rare chronic condition in young women caused a painful acute or chronic urinary retention due to the external urethral sphincter failing to relax. It's often associated with polycystic ovary syndrome, but it can be triggered by gynecological surgery and childbirth. So the sacral nerve stimulation is viable because sometimes it can restore that nerve function. So Tasha, why don't you call me? Call me. Tomorrow's a holiday for us, and so don't call me tomorrow. But why don't you call me Tuesday? I'm going to give you my email address. My email address is easy. It's icnetwork@mac.com. I can connect you with specialists if you want to try to do that. I'm very unclear, as you are, as to what's driving all of this for you. Again, I'm just going to say that when symptoms begin after a surgery, we always think surgical injury. Okay, that something traumatic happened during surgery that they might not have told you about, that might have been damaging in some way. But the other reality, hard reality, is that they put you into estrogen atrophy and they didn't treat it. And they may have also injured your pelvic floor. Maybe you've got some scar tissue with your pelvic floor from that surgery too. So call me and let's talk about that. And we can put together a list of questions for you to give to your doctor to try to answer some of these questions a little bit more thoroughly before you just jump in on having major surgery. Okay, honey? You guys, everybody, I would really appreciate it if y'all could just send Tasha a hug, because she's going through it. I mean, if she's had blood in her urine for 3 years, I've never heard of a patient bleeding so frequently for so long. And I'm not surprised you're getting infusions every month, because that blood loss is real. But I just feels like you're not getting all the information. Tasha said they blame the doctor who did your hysterectomy. Oh, hell, I would too. I mean, have they identified something that he did wrong? Yeah, you call me, girl. You call me. We got your back. We'll try to help as much as we can. Don't you dare give up. Always understand that pelvic pain, you are an anatomical mystery to be solved. I don't want you to assume that there's no hope, and I don't want you to assume that you'll never get better. I think that there are pieces to your story that are unclear that we need to flesh out a little bit more to help you try to identify treatments that they might have missed. Okay. They think it's a nerve and pelvic floor. Exactly. I was right. Surgical injury. They've told you now that you've got a nerve and pelvic floor injury. Okay. So if I were to suggest anything, I would, just to try to get things to help boost your body a little bit in fighting and reducing some of this. PEA, palmitoyl-ethanolamide, PEA, has been studied extensively with a wide variety of pain conditions. Right on the front page of our website, I've got a big article on PEA with all the research. The ICPEA study released in 2019 showed that 87% of patients using it reported a significant and progressive reduction in pain. How does it work? It calms nerves down. So if you've got a nerve injury, this is like an over-the-counter, much less risky version of gabapentin. Doesn't work in the same way, but they do the same thing. But no side effects in the IC study, no side effects in the vast majority of studies. It acts by calming nerves down. I have a very sensitive nervous system. This is what I take. I know, girl. I hear you. So getting some PEA on board for a few months would be a very interesting experiment to see if that would help calm some of that systemic neuroinflammation. The other thing I think you should consider is, where is it? Lactoferrin. Where's my lactoferrin? Must be in my kitchen. Lactoferrin is a new protocol for recurring UTI and IC. So what is lactoferrin? Lactoferrin is a protein found in colostrum. It is a major building block of our immune system. Our body makes lactoferrin. Lactoferrin is a front line of defense for bacterial infection, viral infection, fungal infection. And so we have lactoferrin that our body makes right now in our eyes and our vaginal secretions. We have a lot of lactoferrin. Unfortunately, our lactoferrin levels can vary for any number of reasons, including aging. And so they have been studying extensively the use of lactoferrin from cows to see if that will boost our immune system, and it does. And we had a study released a year ago, last summer, of 31 patients using lactoferrin. And what they did is they did cystoscopies before and after treatment. So they looked at the bladder. They documented redness, inflammation, and Hunner's lesions. Okay, they also measured systemic inflammation through blood testing. Then they gave them lactoferrin for roughly 5 to 6 months. And at the end of the 5 or 6 months, they went back and they looked in their bladder. Red inflamed bladders had become pink and healthy in 28 out of 31 patients. Hunner's lesions virtually disappeared. And when they measured systemic inflammation, guess what? Their systemic inflammation had all dropped, showing that their body was now stronger and more healthy. That same research team 3 years earlier, it was a research team at a university in Italy, did it with recurring UTI. And they found that it helped your body defend itself against infection. The challenge here, girl, is because you are in estrogen atrophy, your bladder right now can't defend itself well. Bacteria are basically just swimming up to the bladder wall and infecting the bladder wall, because you don't have that nice thick coating of mucus that you used to have. And so, what we always have to ask the question, why am I vulnerable to infection? And in a woman, the very first thing we look at is estrogen levels. So you're the perfect person to have come into this meeting, since we were talking about recurring UTIs. You are a recurring UTI patient for sure. And estrogen atrophy plays a big role in that. So I'm really, really glad they're using the estrogen, because that makes your skin stronger, but your immune system has taken a bit of a beating too, and the lactoferrin can boost your immune system and help fight some of that inflammation. So right on the front page of the IC Network website, There's another blog on the lactoferrin research. I want you to read both of those because both of those have a shot. I mean, at this point in time, and this is where I get very annoyed with doctors in general. Oh, Angie saying you're here. Awesome. Is that, how do I want to say this? Sometimes they miss the easy things. It's like, let's do big pharma. The thing is you've done a lot of big pharma and you're not getting better. And so taking a step back, revisiting the underlying cause, doing everything we can to get your body as healthy as we can. We want to get your immune system as healthy as we can. We want to get your skin as healthy as we can. We want to get your muscles as healthy as we can. And those three are going to play and we want to kill the damn infection in the first place. So I think that there's hope for you. I think that there are things that maybe you didn't quite understand that I might have helped you understand a little bit more. But let's call me and let's have a chat, okay? Natalie says, what do we do when lactoferrin causes a flare? I don't know why or how lactoferrin would cause a flare. Lactoferrin, so the IC lactoferrin study had no side effects. And it's considered very, very easy on the body and well tolerated. I mean, it's not a synthetic made in the lab. I mean, it's literally a protein found in milk. So the more common side effects from lactoferrin is going to be stomach upset or diarrhea for people who are more sensitive to that. I mean, Natalie, I completely believe you. I never don't believe people. Did you just, so number one, I would say, okay, where'd you get the lactoferrin? Is it a good source of lactoferrin? Number two, how much did you use? Did you just use too much? I mean, I think it's important to go slow, especially if you're a little bit more on the sensitive. Number three, maybe trying it with some food. Number four, maybe you're sensitive to it. Stacy had said she's been using the lactoferrin from the IC Network shop for about a year with no problems. Good. Stacy, do you believe that it's helped you? I mean, listen, there's a lot of cheap lactoferrin on Amazon right now. You don't know where the hell that's coming from. You just don't know where that's coming from. I will tell you that the researchers use lactoferrin from Australia, which is why we sell lactoferrin from Australia. Use a small scoop in a 16-ounce bottle of water. Natalie, where did you get it? Is it from us? Did you get ours? So if you get the powderized lactoferrin, the problem with just getting the powder is that a lot of it's going to get destroyed by stomach acid. That's why the capsule is better, because the capsule is an enteric capsule, so it's designed to get past the stomach acid, where it can get absorbed in the small intestine and be more effective. The powder itself, I'm trying to remember, was I given a statistic like 40% of, I mean, don't quote me on this, but I think I remember somebody saying like 45% of it destroyed by digestion. It's a lactoferrin brown and it is the powder. Well, and you're saying it gives you a bladder wall flare? I think I would stop it. I would stop it for a couple of weeks. Number one, if any, listen, guys, side effects are real. And if a side effect interferes with your ability to function and it interferes with your ability to live, then clearly it's not for you. And so, do I believe in taking things that are giving you side effects? No, I don't. It causes spasms in your bladder and increases your frequency. I do not understand the mechanism of action of how that would happen, but stop it. Stop it for a month or at least a couple of weeks, get everything to calm down, and maybe your body doesn't like the powder formula. I've never had any. You're the first, but again, I totally believe you. I'm not disbelieving you. I would just back off, let everything calm down, and I mean, it just might not be for you. Maybe you could try another brand. I'm sorry. That sucks. Really sucks because the lactoferrin, there's so much research behind it for so many other medical conditions besides IC, and it does so well overall. It's not a bad idea. I wish I had samples for you. They just don't have. Hold on a sec. Let me see. Yeah, this manufacturer does not have samples. You know, lactoferrin certainly has the potential of changing your biome because it's helping your body fight off infection. And so there's always going to be or pathogenic bacteria. So there's always going to be an adjustment period. I just don't know what to say. Elaine says, could the brand, wait, why do I have my earbuds in? Wait. I have just spent 2 hours with my earbuds in. Oh my God, Jill. That's ridiculous. They're so, I just wear them all day. So Elaine says that she's seen some lactoferrin on the market that contains citric acid. I mean, that's a possibility. Natalie said, you were hoping it would help. I'm now in menopause, dealing with pain in the urethra. You get UTIs more frequently, and they are difficult to get rid of. Okay, but that urethral pain is usually estrogen atrophy in the urethra, honey. You know, the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. It's the first part of the urinary tract to start screaming in pain. So, are you using any topical estrogen products yet with your urethra? I have a really good article on our website, The 7 Causes of Urethral Pain. And so what are we going to look for with urethral pain? Okay, but wait. Now you just said something really important. You said estrogen cream made it worse. Girl, that's like a giant clue. Because if you put estrogen cream on and it burned like hell, that means that your skin is massively compromised. That's normal. If you put estrogen cream on and it burns like hell and it scares you, that doesn't mean that the estrogen is burning you. It means your skin is really bad. It means your skin is really, really compromised. But that goes away. Every time you give that skin estrogen, it immediately absorbs the estrogen and starts to make mucus. It takes a couple weeks for most of that burning to go away. So Did you just try the estrogen once or twice and walk away from it because it burned? I have a lot of women who do estrogen once or twice. It burns, it scares them. They don't touch it again, including a family member. She's like, I'm not doing that. That burned like hell. And I said, now listen, when your skin is dry, anything you put on it is going to burn. Estrogen cream, it's okay. Now, wait a second. It doesn't burn on contact. I took it for 5 days and now it hurts to walk. Okay. Where does it hurt when you walk? Okay. Where specifically does it hurt when you walk? Is it in your vulva? Hi, Estelle. Estelle is here from Ireland. You get a bladder installation. Okay. Okay. So, Natalie. Okay. So, her pain is in her urethra and her vaginal opening. So, okay, you guys, now listen, nothing is off the table. I am willing to talk about anything. There is nothing that's going to embarrass me. It's a little awkward to talk about what we're going to talk about it. So your vulva, right? The outer lips, you got two, okay. Oh, I wish I had a picture. I wish I had a really good picture here. When you, okay, where is my little model? Darn it, darn it, darn it. Where is it? Is it up here? Okay. Okay, this is the closest I've got to a model. So I just want you to pretend that there's skin. Okay, so here we go. So at the very base, underneath your vulva and your labia, we have the urethra, the vagina, and the rectum, right? So again, I want you to pretend that this is covered with skin. So these are what we call mucous membrane structures. They're meant to be moist. So think about how painful dry mouth is. When you have a dry mouth, it hurts and you go get water. When you have a dry skin here, we have dryness at the entrance to the vagina. We've got dryness in the urethra. We've got dryness in the vagina. We've got dryness in the lips, the labia, the inner labia and the outer labia. Okay. So when they're nice and moist and you're walking, they just slide. You don't even notice them. You know, it's not like they never move. When you move, they move. And the whole point is that they're very slippery and they slide very easily on each other. When they get dry, they don't slide and you start to feel it and it's uncomfortable. It's happened to me. And that's when you use something like vulva balm, which will help it slide again. You use the topical estrogen to help that skin make natural mucus. The most natural thing you can do is use topical estrogen because you're helping your body make your own natural moisture. But Sometimes that's not enough. And sometimes you have to augment that with another very, very, very light, slippery oil that will make sliding very, very easily. So a lot of times that discomfort when walking on your vulva and down there is just related entirely to dryness. So I would encourage you, number one, to make sure that, you're working with a doctor, they've given you estrogen cream, that's good. It may also be that they've given you an estrogen cream that has a preservative in it. Sometimes patients react poorly to Premarin or estrase because they have preservatives in them. And that could cause a little bit more superficial irritation on the skin. So a lot of us get a preservative-free estrogen cream. I do. I get mine from the former Women's International Pharmacy in Arizona. And when my doctor, my urologist, first prescribed it for me when I was 52, and I was having all this urethral pain, I was just like, oh, okay. And then I went to my gynecologist and he said, listen, I'm not giving you any brand name. You're too sensitive. We're going right to the preservative-free formula. And I'm so grateful to that because that worked for me. So concept number one is that burning is just because your skin is very dry. Concept number two is that you need a little bit more protection on your skin down there. So using coconut oil or vulva balm would be good. Concept number three is maybe there's a preservative in that estrogen cream that they've given you that's irritating you down there. It's happened before. You can always ask for a preservative-free formula. The harsh reality here is that the quality and health of your skin matters. You can't walk away from it. Don't walk away from it. You just have to say, this is bothering me. I want to try something else. Because if you just let yourself get drier and drier and drier, you're going to be in a lot of discomfort shortly. That skin is meant to be moist. Lori there says she gets a compounded estrogen. Karen said, what do I recommend as a panty liner? Because that can be messy. Oh, easy. Hold on. Cora's. Let me show you. Best panty liner ever. Cora's, made with organic cotton. 100% organic cotton top sheet. This is what I use when, because I am older. And what's cool is they have small ones. I mean, look at how small this is. And then they have bigger, they have all sorts of different sizes. So I use the regular bladder, what do they call it? Bladder liner, free to move bladder liner. I've never had a problem with these Cora. They're carried at my local supermarket. That's where I get them. Come on. Can I shut it? There we go. So I love my Cora panty liners. Estelle, what kind of bladder installation are you getting? And how is care in Ireland? Europe is funky. They were ahead of the game. They were way ahead of IC and care in the United States. And then they plummeted back to the dark ages. Natalie said, my gynecologist told me the compounded estrogen is the same but more expensive. She then referred me to a urologist. I am seeing a hormone specialist this coming Friday. I'm hoping she can help me. Girl, that's crazy. Because I'll tell you, Premarin can be well over $100 to get per month. And my topical estrogen, I pay $70 for 3 months. So compounded estrogen is often much cheaper than the brand name. You just have to call around, and there are some national compounding pharmacies that are like, I use the former Women's International Pharmacy. They have a new name now, but they're fantastic. And that's where I get all of my estrogen. I've got a bunch because I also inherited some of my mother's backstock when she passed away. So I haven't had to have it filled in about a year, and I probably have another year's worth I can use. You're welcome, Natalie. You are welcome, my friend. You are welcome. Lori says, my husband has chronic neck nerve injury. He toggles between gabapentin and Peora. He finds a Peora very helpful. Yes, love it, love it, love it, love it. Like, I really, really think, listen, the future of IC is so much better than it was even 5 years ago, because 5 years ago, patients were told it's incurable and they gave you Elmeron, and then, God forbid, the longer you use the Elmeron, the greater the risk of eye issues, etc. And now we have really viable, affordable, over-the-counter supplements that are worth trying, that have IC research behind them, and like PEA research. There are dozens and dozens of studies showing PEA is safe and effective for a wide variety of pain conditions, from acute pain, chronic pain, surgical pain, shingles, burning mouth syndrome, fibro. And as Lori's husband said, it's helping him with his chronic neck pain. So PEA is like foundational now for the future. That is the true next generation supplement. And then I think lactoferrin is the future also. I think lactoferrin is helping a lot of patients. But the PEA, man, the applications for PEA are so wide for anybody who's dealing with chronic pain, nerve pain. It's exciting because it's affordable and it doesn't come with the side effects of the gabapentin. And there's no risk of addiction, nothing at all like that. You know? Anyway, I mean, that excites me. I am trying to keep myself hydrated. So I'm trying to drink as much as I can during the day. I will notice for me, because I now have a little bit more estrogen atrophy going on. So normally I get up once a night, and it's usually at the 4-hour mark. But if I have, okay, now remember, my phenotype primarily is pelvic floor widespread pain. So I can drink lemonade, and I usually don't suffer for it at all. I do not do anything with caffeine. Oh my God, if I do caffeine, that amps my nervous system up. It gives me tachycardia. God forbid, could put me into AFib, which is the last thing I want. So you can't pay me to drink coffee or eat chocolate right now, but I can do lemonade. However, if I do lemonade, and again, never full strength, it is very, very diluted. It's like a quarter cup in a big glass of water. If I do it before bed, that is always a mistake, and I will end up getting up at least one more time a night. And I relate that entirely to just estrogen atrophy now. My goal here is I want to work until I'm 70. My goal is to keep the IC network alive and kicking for another 4.5 years. But once I'm 70, I mean, I'm always going to help IC patients, but I'm going to be changing a few things. Knock on wood. Knock on wood. One of which is I'm going to take a vacation for the first time in 25 years, and I'm going to Hawaii, and I'm going to sit on the beach for 6 months. Natalie said, I've not had coffee since 2004 and lemonade is a no-no. Girl, I stopped drinking lemonade 30 years ago when I was first diagnosed with IC, and I stopped drinking coffee after I started having. You live in Hawaii? What island do you live on? I have family in Hawaii. I have family on the Big Island and family in Honolulu. What island do you live on? I'm just, oh, you love Hawaii. Yeah. My brain, I just keep thinking of the Kahala Beach outside of Honolulu, which is a little community beach. The tourists don't go there. And like, I don't care about the risk of skin cancer. I just want to sit on a beach and warm up because, like, here's the weird thing. When I had my mastectomy, I lost my fat, right? I am like, there's nothing there. My skin is on top of my ribs. And I am so cold now. I am always cold, even in the summer, because I've lost that fat padding. And so my brain just wants to go sit on a beach so bad. If I won the lotto, and I do play the lotto, it's the only gambling that I do, I'm going to buy a house on the beach. Hopefully with fiber, with a fiber internet, so I can still do my work, but I can still go sit out and sit in the sun for an hour. On the other hand, I will say my go now for a week. Yeah, I don't know. I have barriers to traveling right now. I have a lot of frequent flyer miles. It's not the cost, it's the fact that I can't sleep in a regular bed because my jaw dislocates. That's a whole COVID dental problem. And I don't know how I would sleep in a bed without dislocating my jaw badly. You've been to Maui. You were married on Kapalua 26 years ago. Want to go back for a 30th anniversary. Yeah. I just wish we could transport like Star Trek. I mean, I would just transport me there, please. That would, the whole flying thing. And then if I didn't have this jaw thing, see, I had a tooth kind of explode right before COVID, and it was a molar on the left side. And literally like 2 days before, I had to have an emergency extraction of this big molar. It was an old, bad job that a dentist did. And for the first year of COVID, they shut down the dental clinics, and I only chewed on my right side. I couldn't chew on my left side. And that badly, badly messed up my TMJ. And finally, when the dentist could get care, it still took months to get in. And by that time, I had badly stretched out stuff, and it's just a freaking nightmare. I can lay like this, but I can't lay flat. And even if I'm laying like this, I'm popping my jaw. It's this side. I'm popping this jaw back into place. It doesn't help that I talk for hours at a time. I'm sure that that's made it worse. But I mean, Lahaina, it's shocking what happened. No, I don't know about you guys, but one of the ways I entertain myself is I do what I call Zillow porn. And that means that I will just go to Zillow, and which is where to find a house. You can search for houses that are being sold or for rent. And I just go through all the places in my mind that I think that I would like to live. And I know for me that I can't be anywhere cold now. I mean, I'm struggling where I am, and I'm in Northern California. I have to be somewhere warm. I just don't have the fat protection anymore. And so I'm looking at San Diego and I'm looking at Hawaii. You do it too. I mean, you know, I like Florida. I just don't want to live in Florida right now. Um, and yeah. So anyway, you'll find me on Zillow several times a week for a half an hour at a time, just looking. Oh, I could do that one. And then like the other thing too is I don't want something right on the beach because I think about tsunamis. So it's just like, okay, I want to be above the beach just a little bit, but I want to be able to walk down to the sand. I'm telling you, the things our brain does is pretty funny. All right. Well, so we've been here for 2.5 hours. You live in Phoenix, and winter is truly. I love Arizona. Oh, and oh my God, I'm so sad about Nancy in Tucson. Like that has the whole country in. Nancy Guthrie was taken from her home at like 3 in the morning or 2:45 in the morning 3 weeks ago, and um, I mean, I'm just like, it shows me, like, my first reaction to it was, who would do that? My second reaction to it was how important it is to have really good safety. And my mother said when she died, she said, "You're going to get a dog, right? You need a dog. Don't live alone. You have to have a dog." And I haven't wanted to get a dog or a cat yet, just because I'm still just trying to get through breast cancer and recovering. I didn't want to be responsible for any other living being. I just wanted to take care of me for a while. But like, I'm thinking Doberman. I've always wanted a Doberman. It's just my home insurance won't cover it. But having it, just as a woman, as a single woman, it just scares me. I pray to God that she's alive, and I just pray to God that they find her soon. I can't even imagine what her family is going through. Yeah, she had cameras. Yeah, and she had cameras, but she had canceled or wasn't paying the monthly, so it wasn't easily accessed. I guess Google did something where they were able to pull some of the camera footage anyway, which is great. Um, but in the end, we have to have people checking on us every day. And there's an app where you can, if you live alone, you can set somebody up as your contact, and you just check in on the app once or twice a day. And that then notifies your contact you're okay. And if you don't check in, then they know to immediately check on you. I mean, Gene Hackman, when he died in New Mexico, they didn't find him for like 5 days. And he's a famous Hollywood actor. Like, where was his family? So we just have to look out for each other, my friends. You've got elderly people in and listen, anybody over the age of 50, check up on them once a week at a minimum. And if they're over 70, check up on them every day. Why are my glasses crooked? My glasses are crooked. Are my glasses crooked? All right. Stacy said, the police tell me the dog is the best. My alarm went off and we didn't get the police to our house. Our dog sounded like she would tear them apart. They said she's better than an alarm. Yeah. I don't, I was just so traumatized and exhausted by caring for my parents as they died that the thought of caring for being responsible for a living being was just impossible for me. I just needed to care for me for once. And now it's been 2 years but then a year of cancer. So I'm getting there. I'm definitely getting there. 100%. Yeah. I've always wanted a Doberman. I had a neighbor when I grew up. We had a guy across the street who was a friend of Sam Elliott's. You know that actor Sam Elliott, the cowboy? He actually ate on my street. He ate her because the guy who lived there, his name was Logan, came down urgently and said, I need some pants. We're like, why? He goes, because Sam Elliott's coming. It's like, okay, you can take what you have. So Sam Elliott walked on the street right where I live. Anyway, Logan had the two most loving Dobermans, and they let me crawl all over them when I was young. And I have never forgotten those wonderful dogs. And I've always wanted to have a Doberman. Natalie says she loves Sam Elliott. Man, did you see him in the latest season with Billy Bob Thornton? The Texas Oil one. What's the name of that? I forget the name of that series. Anyway, oh my God, he's so good. He deserves an Emmy Award for his acting. Anyway, I'm thinking Doberman, but the challenge is I've got nephews who have young kids and they're going to be afraid of the Doberman. And if I have to evacuate from a fire, I would usually end up there. And would they allow me to bring a Doberman up to the ranch? We can talk ourselves into all sorts of things. In the end, it's about training anyway. Other challenge is I'm older and I can't really be lifting a big dog. But I need a dog. Yeah, come on. What's the name of that Billy Bob show? Come on. I mean, it's like right on the tip of my tongue. Texas Oil Show, Billy Bob. All right, hold on. Landman. Yep. So good. And then tonight they're releasing the next Dark Sky, which is the New Mexico, no, either New Mexico or Arizona Indian mystery series. So I can't wait for that. That's what I'm going to watch after this meeting. All right, so hold on a sec. Hello, Tobias from Germany. Hello, Tobias. I probably have a question too, but I don't know if it's in this live stream session or if you can help me. You can ask, sure. Go ahead and ask the question. I am up for it. Yep, Natalie, Landman. I will take your question, Tobias. Go for it. What state are, for those of you who are from the United States, where are you from? What state are you in? So we are live streaming right now on YouTube and Facebook, just for those who are wondering. And when we do these meetings, usually during the meeting between the two, we'll get 40 to 50, sometimes 75, 80 people watching. But then in the days following, we'll get several thousand patients will watch watch this meeting. Bye, Stacy. Thank you. I'm going to try. Carol is from Pennsylvania. Natalie is from Texas, originally from Illinois. I'm a California girl through and through. I was born here. I was born in Santa Barbara, California. I love my state. All right, Tobias. I don't know if you're still here or not, but feel free to ask your question. What else is going on in the IC world? I've got a blast email that will be going out probably early next week. We've just ordered a bunch of new products for the IC Network shop, but I haven't added them to the store yet. So no point in me talking about those until I get them actually added to the store. I've got about 4 or 5 videos that need to be prepped to go into our master class. I've got, so we just finished our winter magazine. So that's done. Our magazines are anywhere from 32 to 40 plus pages. And we've got 2 or 3 books in production, including one on the floor over there, which is going to be our new medical records kit. I'm just working on a bunch of series. All righty. So I'm happy to stay as long as you guys have questions. It is almost 4 o'clock here, almost 7 o'clock back east. I don't know if anything. Oh, you guys, the Olympics. I was heartbroken when Ilya Malinin kind of flamed out. I was so sad. I feel so sorry. You know, the stage, putting all that pressure on a 21-year-old is brutal, absolutely brutal. The Olympics have been fun to watch. I just finished, what was I watching last night? I'm just kind of going back to old school stuff more than anything else. Yeah, it was heartbreaking. I was sitting here. I mean, I was watching the live stream going, and I just he landed the first jump, but when he missed the quad, he missed the quad. I forget the name of the jump, the hardest jump ever performed. He's the only one who's actually landed it, but he missed it. And then he just lost his confidence. But he has a gold medal from the team competition, so he's not leaving the Olympics without a gold medal. I just, don't want it to affect his self-esteem too much. Well, I think we've come to the natural end of this meeting. So I fully intend to be here next Sunday. Knock on wood, knock on wood. In the meantime, you can always reach out to me through the IC Network, icnetwork.org. If you go to the top of a page, our 800 number is right there. Feel free to call. Please know that I take phone calls on a first-come, first-served basis. If you call and you get my service or I respond on my cell phone, I can't talk right now, or can I call you later? It just means I'm already working with somebody. Just know that I will try to call you back when I can. The patients who get priority are the patients who have confirmed coaching sessions, but I'm available even when I'm not doing that. All right, so don't hesitate to reach out if you have questions. Bye, Johanna. All nice to see you. Nice to see you. Thank you, Judy. Be well, everybody. Stay warm.